This is the 11th webinar in this series focused on community-defined practices for ethnic and cultural populations, brought to you by the California Institute for Mental Health, or CIMH, and our Center for Multicultural Development, and presented by our partners, the Asian Pacific Policy and Planning Council. We want to thank our sponsors, the Mental Health Services Act and the Department of Healthcare Services, for supporting this webinar series. And our webinar today, entitled Intervention Within the Context of Asian Pacific Islander Families and Communities Across the Age Span, will address cultural considerations for direct practice with Asian Pacific Islander individuals and families. Practice models with children, transitional youth, adult, and older adult will be discussed with cultural applications of engagement, wellness, coping, resilience, and community integration. It's a privilege to have with us today's presenters, or all of our presenters today, Winnie Hsieh, Dr. Hsieh, Dr. Brett Sevilla, Ms. Angela Kang, and Ms. Yvonne Sun. So Dr. Hsieh is a clinical psychologist and the program director for Asian Pacific Islander Child FSP Collaborative at Asian Pacific Family Center of Pacific Clinics. She's also an adjunct professor at University of the West and Argosy University. She's been actively involved in the community mental health setting and dedicated her professional practice in working with underserved, unserved, and underprivileged populations. Specifically, her focus is on working with API community to enhance the API's mental health and well-being. Dr. Hsieh has done numerous workshops and presentations locally and at national conferences on engaging API communities in mental health treatment and outreaching to API communities to raise awareness of mental illness. Dr. Brett Sevilla is the medical director of the Asian Pacific Counseling and Treatment Centers and is a clinical instructor in the Department of Psychiatry and Biobehavioral Sciences at the David Geffen School of Medicine at UCLA. Bachelor of Science with distinction in chemistry from Stanford University, and earned his medical degree from the University of California in San Francisco, where he stayed to complete residencies in general psychiatry and child and adolescent psychiatry. As a child of a Filipino-American father and an Irish-American mother, he has an interest in identity development in multiracial Asian Americans since his undergraduate years, when he was interviewed by the New York Times and Good Morning America about a multiracial student organization which he helped to found. He has given presentations on this and related topics at the annual meetings of the American Psychiatric Association and other venues, and gives annual lectures on Asian cultural issues and mental health at UCLA. Ms. Angela Kang. Ms. Kang is a licensed clinical social worker and the program director for API Collaboratives, a program of special service for Groups Alliance. The API Collaboratives program includes the Asian Pacific Islander Adult Full Service Partnership, field-capable clinical services, and the Innovation Samoan Integrated Service Model. Ms. Kang has 15 years of experience in the fields of mental health. She's worked in various capacities from clinician to supervisor, and in diverse settings, which include locked psychiatric settings, to the field. She has clinical experience serving individuals, families, and communities with the focus on the API population. Finally, Ms. Yvonne Sun is a Chinese-American born in the Republic of China, and she immigrated to the United States when she was 7 years old. From a young age, she witnessed the challenges faced by immigrants due to language and cultural barriers. Raised by her paternal grandmother, Ms. Sun began to recognize the various signs of aging and how it further challenged her grandmother in accessing and utilizing services to better her grandmother's health and mental health. In 2003, following the death of her aunt, Ms. Sun witnessed how grief contributed to the physical, cognitive, and emotional decline of her grandmother and the various challenges that her grandmother faced in receiving and benefiting from the mainstream healthcare system. In 1999, Ms. Sun joined the Special Service for Groups. Through her work at SSG, she was able to leverage the knowledge that she gained through her professional work to improve her grandmother's overall health, as well as utilize her personal experiences to work with the Asian and Pacific Islander aging community. So at this time, it is my pleasure to turn it over to Ms. Angela Kang for a welcome and an overview. Thank you.
Thank you so much, Christy.
Mm-hmm.
We want to thank CNMH for this opportunity to be a part of this webinar series. We are here today as a collaboration of partners of the Asian Pacific Policy and Planning Council. APCON is a coalition of community-based organizations that advocates for the rights and needs of the Asian Pacific Islander American community in the greater Los Angeles area. Today we'll be discussing culturally competent practices with APIs across the lifespan. In our last webinar series, we'll be discussing community-defined practices, the development and implementation of caring for our families. Today we will be discussing components of culturally competent practice and important factors to consider. The API community is a richly diverse group of individuals. We differ in terms of language, religion, immigration, history, educational level, population, foreign-born population, and that's just to name a few. It's precisely due to this diversity of needs that we enhance and maximize capacity to work with the API community. We will be discussing collaboration in relation to direct service. We saw how important it was in outreach and engagement in the first webinar, and we will see the importance of it with community-defined practices in the third webinar series. We will be discussing issues specific to each age group: children, transitional age youth, adults, and older adults. We will be discussing the relationship of cultural factors to direct service for each age group. And lastly, we will be sharing strategies and interventions directly from our experience with individuals and families across the age span. And at this time, I wanted to turn over to Dr. Hsieh, who will be talking about working with API families and communities. Thank you.
Hi, this is Dr. Hsieh. Good morning and welcome everyone to this webinar. I'm going to start by talking a little bit about API Chalk Collaborative, and that would be a good starting point to talk about the diversity within the population that we serve. To start off, let me change the slide. API Chalk Collaborative is actually a collaborative between 4 different agencies. And as a lead agency, it's Asian Pacific Family Center, and our partners include APCTC, PACS, and KYCC. And we serve service area in LA County, service area 2, 3, 4, 5, and 8. As you all know, LA County is quite a large county, and within different service area, API community is actually quite diverse API community within different service area. So for example, service area 3, we have more Chinese American and Vietnamese American population versus in service area 8, it's more Southeast Asian. So we'll talk a little bit about the diversity and how that will work into, or you can look at that into your work with API communities and working with the children and families. Currently in our API Child Collaborative, our demographics of clients served include Vietnamese American, Chinese American, and within Chinese Americans, we're talking about different language capacity as well. That include Mandarin-speaking clients, Cantonese-speaking clients, Chuchao, and other dialects. There are also Korean American, Filipino American, Cambodian American, Samoan, and Japanese American. So when we talk about diversity in API community, we're not just talking about Vietnamese or Chinese or Korean, but we're also talking, including our multi-ethnic groups, either by marriage or by partnership. So within our collaborative, we also serve clients or families that are Chinese Vietnamese or who are Japanese Korean. So again, within that, I wanted to bring in mind, and something to keep in mind as we move forward to in our presentation, that the diversity within the diversity. So I talked briefly about the different language capacity that we have within Child Collaborative, and I just wanted to bring awareness that the information that I'm about to present is actually gathered from clinical and practical experiences in our field-based services. So API Child Collaborative offers the FSP service, and many of you know that FSP service is intensive mental health services that's intended to be provided in the field. And working with the family of API descent is a little bit different, and we will talk about how that has implications for the service provider. So to start off our presentation, I want to talk a little bit about culturally competent practice. And when we talk about culturally competent practice, we're talking about cultural competency, clinical competency, and also language and cultural matching services. For clinical competency, well, actually, for cultural competency, I want to bring in awareness that providers working with API community should have some awareness and previous knowledge about how different Asian cultures and their histories, how that make up the culture, and how that impacts the family. Some example could be the difference between North Vietnam versus South Vietnam. And for people who immigrated from Vietnam, how that different region actually affects their outlook and worldview. And also for people from Taiwan versus China, and how is that different based on their political background and the environment in which they grew up. Another example would be individuals from Hong Kong versus Guangdong, and Chinese Vietnamese versus Chinese from China. So all these are examples that I will be talking in the presentation. And lastly but not least, working with Southeast Asian, we wanted to make sure that also individuals working with Cambodian community has awareness of what Khmer Rouge is. And I can talk briefly about that as we talk further. As far as clinical competency, that's pretty basic as far as working with this population, basic in terms of our school education, knowing different theories and what might work better with your clients and whatnot. So I'm going forward with the assumption that everyone has the basic clinical competency in working with our clinical population. So the third item is language and cultural matching services. I wanted to highlight this one only because a lot of times when we work with individuals in the community, we hear that some agencies perhaps are equipped with or staffed with individuals who are, let's say, Vietnamese speaking. But that in itself does not equate to being culturally competent, meaning that the individual may be second generation Vietnamese American, and to have this individual represent the Asian population or the staff that are working with the community in itself is not sufficient, because first generation, second generation, there is a generation differences, and their experience and the environment in which that they are in could also be different. So simply by having staff that speak the language does not mean that the service itself could be culturally matching to the client population you're serving. Okay, so I skipped something. Hold on. Okay, so the next slide is talking about diversity within API community. And I want to talk about that and its implications for service providers, which will lead to our second point, which is staff's own challenges with stereotypes and cultural biases. I want to give some examples about the population that API Child Collaborative actually serve. Our populations are largely Medi-Cal population or indigent. With that said, it's already carrying its implication that these are underserved or unserved population. And these are lesser than privileged clients. And a lot of our families are actually of refugee status, and their mental health, the children's mental health challenges actually is affecting their school performance. So I'm going to give a few examples of the families that we serve to kind of illustrate the point. We have Vietnamese families that we're serving to which the family, which the parents, or even the grandparents are the boat people. And when I say boat people, I mean that these are individuals that escaped from Vietnam anywhere between 1975 to 1995. And through their experience of traveling via ocean and on the boat, that many of them actually witnessed a lot of trauma, meaning that their relatives got ill over the journey and they have to be tossed overseas, or they're piracy over the sea, and then they are experiencing a lot of trauma like rape and other physical violence that for the children that they have to witness this. So growing up in that environment and being transitioned into different refugee camps, that itself creates a very unique culture for the population that we serve. So this is an example to illustrate how different this could be, the diversity within the API community, and something that we need to know about our clients in order to serve them appropriately. Another example is that recently we have a case is a Filipino mother and daughter. They immigrated to U.S. in search of a better life, but it was the daughter's first psychotic break in U.S. So without the support of the family back home, how are you as a service provider going to link them to the resources here in the community? So these are just some examples to bring to light. And I want to talk about the stereotypes. A lot of times going through schooling for the service providers, we talk about model minorities. And our client population a lot of times actually defies that stereotype because they are not from well-off family. A lot of them are not, even though we still have a small population that they are from middle-class family. But most of our families are actually not. And so we want to keep that stereotypes and cultural biases in check and know that not all of our families will fall into that stereotype, and really challenge your own thoughts and your own perspective and biases. Next, I just wanted to offer a map of Asia to highlight the different diversity within the culture. A really quick overview on the ecological system theory, and to highlight how that would actually affect API community and also the children as they grow up in a system. So microsystem, we're talking about individuals' gender, age, attitudes, and individuals' interaction with others. And mesosystem, we're talking about the immediate family, neighborhood, and then exosystems, and that's the community agencies, neighborhoods, extended family, then macrosystem, which is cultural value, laws, customs. The last one would be chronosystem, which is environmental event over lifespan. Now for API communities, we do focus on the first three, but I wanted to also point out macrosystem only because depending on the immigrational status, this could really affect the family belief system, and that would in turn affect, as a service provider, how you would interact with the family and how they would view you as a service provider. So again, there's strong focus on meso and exosystem, and we wanted to look at their cultural values and acculturation stages because, again, that would affect how they perceive you as a service provider. So something to highlight is that for service providers, you want to understand the basic Eastern dimension of beliefs, interdependence versus independence, which is more Eastern value, fulfill oneself versus duty to family. Again, it's a difference between Eastern culture and Western culture. Being expressive versus restrained. So these are some values you want to keep in mind as you work with our API families. Now, for API communities, a lot of time problem solving, I'm talking about mental illness in the family as a problem and challenge. And the way the family may solve this problem is actually a lot of times defer to authority. So when you're going in as an expert into these families' life, You want to think about how you conduct your team meeting, because it's very natural for these families to just kind of give you the control to say, okay, go ahead and take it, fix my child. But then how are you going to bring that power back to the family and empower them to say that, yes, I know a little bit more about mental illness, or I know something about mental illness, but you really know your family the best. So how do you empower them to actually take charge of their life when you are an expert or part of their family at that point? So working with API children 0 to 15, when you work with API youth, the work is really with the family. So a couple of things to talk about is that it's not atypical to have multi-generational living together. And usually the pecking order is from elder to the youngest, and male over female. Typically, growing up in a more traditional household, it's one-way communication, meaning it's parents to children. Usually there's not a neutrality, as in many of the Western culture. And values, this is important. Values taught at this stage is actually relationships, respect, responsibility, and role. So the way I say it is the 4 R's. So to highlight that, I wanted to bring a quote from Confucius. It says, the superior man, while his parents are alive, reverently nourishes them, and when they're dead, reverently sacrifices to them. And his thoughts to the end of his life is how not to disgrace them. So that kind of capture the essence of the values taught in a very traditional Eastern family. It's about responsibility, it's about relationship to your elders, and it's about respect to your elders. Now, as service providers, the challenges that you're going to face is that how are you going to work with a kid who is growing up in this bicultural environment? So at home, they're adhering to one set of cultural values, but at school and in their bigger environment, they're actually being constantly exposed to Western culture. So there is that cultural clash. And so how are you going to help this child find the balance to maintain the harmony relationship within the family, but they can also function in the Western culture as well? Which brings us to the must-haves in the service provision: cultural awareness, knowledge of basic developmental theories, openness to learn different cultures and how it affects the community's view on mental illness, and how do you combine both in your work with the family? Because knowing the developmental theories is one thing, but knowing culture is another. How do you combine them to make it culturally appropriate for that particular API family is also another thing. The concept of holism is also important to note. As defined, is the sum of all elements that are bigger and more complex than just individual parts. So we're not just looking at the culture, just looking at the language, or just the family makeup, but we're looking at the relationship between all these elements and what makes that individual unique. As a service provider, you have to strike a good balance between expert versus partner. So this is empowerment versus meeting cultural expectations. As mentioned previously, they're going to view you as an expert, they're there to fix their child. But you, as an expert, how do you position yourself so you are also a partner in this? And once you do, which leads to our next point, which is the role adaptability. Because as a therapist or a case manager, in the family's perspective, you could also be the therapist. And the therapist could also be the case manager. But they don't have differentiation between your psychologist versus social worker versus MFT. For them, everyone is social worker. Everyone is therapist. Everyone is a teacher to the family. And then they're also coach to their kids and mentor to their kids. So in the family's perspective, your role is very adaptable. And in our learning in school, we talk about boundaries. But that could be kind of blurred when you work with API communities. So as you initially start working with a family, you have to do a lot of outreach. And outreach is actually going to be throughout the treatment. We don't want it to perceive the family as being unmotivated just because our outreach didn't work. An example of our work is that with the Taiwanese female client, 14-year-old, we were working with a family, and the families were really happy to let us into their home to help their child. But it was not until 3 months later into the treatment they disclosed that there is actually a family history of schizophrenia. Because for the first 3 months, they did not see us as part of the system. They just saw us as an expert, and they did not want to disclose their family problem to us. So it's not until 3 months later, when a relationship with family built, that we were able to get that additional family history presented. So outreach and be prepared for rejection. And throughout your initial treatment, you want to stigmatize mental illness and do more outreach. And tolerance for the temporary undefined boundary setting. There's going to be a lot of gift giving in the API community because they wanted to show you how much they appreciate your work with their children. So during special holidays, they wanted to give you special gifts. So then how do you as a service provider receive or not receive, and how do you reject these gifts? And knowing that receiving gifts is actually a cultural norm in Asian culture, if they view you as a teacher, they wanted to show their appreciation, and they will give you gifts. So then how do you have a conversation with your family? So as you progress through treatment, there's role clarification, more outreach, and helping the family define what mental health treatment is. And then focus on family first in your initial phase, and then progress into client focus, into your work with the client. When you move into active phase of treatment, again, there's going to be more outreach. I put that throughout treatment because anytime through that, if they start feeling that it's a system and them sort of separation, you could very well, or you could expect a family is going to slowly withdraw. Again, there's their view of the expert, and they want to defer everything to you. And a lot of times for service provider, they are going to view that as resistance. But again, you have to have better and clear understanding of what the respect means in Asian culture, especially to authority. And once they view you as the authority, it's natural for them to take on that quieter role, to not say no to anything you said or challenge you, because you are a service provider and you are an expert. So again, you wanted to continue to bridge that spectrum of expert versus partner, and continue to define that for the family. So at the end of your treatment, I continue to put outreach in there again. And you're going to do more role clarification, because at the end of treatment, you build a certain relationship with the family, and they're going to start seeing you as part of their family system. And they're not going to want to transfer or transition into a different program. And so you wanted to do a lot of role clarification and continue to encourage and empower them, and building on their strengths from a cultural perspective. I kind of ran through everything pretty quickly because we have very limited time. But I do want to end my part of the presentation with a proverb. It's a Nigerian proverb. It says, "It takes a village to raise a child." It's truly what it is, even in Asian culture. I know this proverb comes from Nigeria, but it's the same thing in API community. It's a lot about family, extended family, and community. So without further ado, I want to turn the presentation over to Dr. Brett Sevilla, who will present a bit about Asian American and working with transitional age youth.
Okay, thank you, Winnie, and good morning, everyone. My name is Dr. Brett Sevilla. I'm a child and adolescent psychiatrist as well as an adult psychiatrist, and I'm the main psychiatrist for our agency's Child and TAE full-service partnership programs. For those of you who may not be familiar with the concept of transitional age youth, this refers to individuals who are transitioning from childhood into adulthood, and more specifically, the Mental Health Service Act defines this age group as being 16 through 25 years of age. So this is an age range that encompasses late adolescence and early adulthood, to put it in more traditional developmental terms. So what happens developmentally during adolescence and early adulthood? Well, a lot, if you can remember back to your Psych 101 days. As you may recall, Erik Erikson was the German-American psychoanalyst who emphasized that human development occurs over the entire lifespan, not just during childhood, and that success at each stage of development is dependent on developing the ability to manage the tension between two extremes of a characteristic dilemma. The lower end of the Tay age range falls in Erikson's fifth stage of development, which is usually referred to by its characteristic tension between identity and role confusion. I'm sorry, we're ahead a slide, I think. Oops. Okay, I seem to be having a little problems going backwards with the slides. I'm trying to go back to the second slide.
Okay, is that the slide you needed?
This is the one, yes, thank you.
Okay, perfect.
Okay, great. Sorry about that. Okay, so again, the lower end of the Tay age range falls into Erik's fifth stage of development, usually referred to by its characteristic tension between identity and role confusion. So the adolescent in this stage of development is trying to answer the question, who am I and what can I be? And the process of answering this question, which ideally leads to a state of identity consolidation, is typically manifested by one trying on different identities. So this takes place through association with different peer groups and may manifest as changes in styles of dress, religious or political beliefs, interests or hobbies, or changes in college majors, as was the case for me, and differing musical tastes. Questioning parental values and developing one's own distinct opinions while exercising increasing degrees of autonomy are also common and a frequent source of consternation to most parents. On the other hand, the risk of role confusion is constantly present, threatening to leave the individual unable to make commitments, drifting between jobs, relationships, towns, and so forth. But the successful completion of this phase leads to increased capacity for mutually satisfying relationships, thereby setting the stage for Erikson's sixth phase, characterized by the tension between intimacy and isolation. In this phase, the existential question is, can I love? And when a person successfully negotiates this phase, they not only experience healthy relationships, but the resulting stability in relationships enhances one's ability to cope with frustration and conflict, and one's sense of confidence in being effective in his or her roles or occupation. Balancing this potential is the risk of isolation, characterized by withdrawal, conflictual, exploitative, or aloof relationships, depression, or substance abuse. Now, it's important to recognize that most of the developmental models that we learned in college and grad school focus on individual development. And while this may be perfectly appropriate in a Western context, this emphasis on the individual actually reflects a Western cultural bias. Not all cultures focus on the individual, and this is especially true for most Asian cultures. Furthermore, when relationships are focused on in Western developmental models, the emphasis is usually on dyadic relationships, either between romantic partners or between parents and their children. This is also in marked contrast to most Asian cultures, which emphasize the importance of one's role within the extended family and one's identity as being inextricably linked to that role. So for the Asian American Tay, who functions in two very different cultural contexts at home and in the outside world, the differences between the two cultures can lead to some additional conflicts that Erikson didn't really address. Whereas Western culture emphasizes the importance of becoming one's own individual through a process that recapitulates Mahler's separation individuation phase, an Eastern perspective emphasizes collectivism over individualism with successful development leading to a fulfillment of one's role and obligations within the structure of the extended family. And whereas the Western adolescent will use his or her peers or organizational affiliations as primary reference groups, the traditional Asian adolescent's primary reference group remains the family. And while American culture is certainly full of images and lore touting the ideal of the rugged, self-reliant, and independent individual who becomes a full adult at age 18, Eastern cultures tend to emphasize harmonious interdependence between people, especially within one's family network. But in exchange for being able to rely on family support, one must in turn fulfill role obligations within the family, including deferring decision-making to one's elders, thereby subjugating one's own preferences to the hierarchy within the family, and thereby foregoing autonomy. So a typical Asian American Tay is likely to feel torn between culturally based obligations to one's family and the desire to make decisions for oneself. This can manifest in conflicts over choices of significant life decisions, including those listed here. And as you may recognize, these touch on many of the same identity and intimacy issues that Erikson had laid out in his developmental models. But these conflicts can be both external and internal. External in the forms of arguments with family members, or internal in the form of guilt about going against one's family's wishes. So for illustration purposes, let's consider a couple of hypothetical case examples that are based on many of the cases that we've encountered in our clinical work, and then we can think about how to begin to bridge the gap between these different cultural perspectives. So our first example is a common clinical situation that we encounter often. A 24-year-old man with schizophrenia who is repeatedly hospitalized due to noncompliance with medication. Upon further exploration, you discover that his uncle has been telling his parents not to give him the medicine because it will cause brain damage and make him crazy. So here we see at least a couple of significant cultural issues. Probably most obvious is the uncle's stigmatized view of Western psychiatric medication as being harmful and a cause of mental illness, but also apparent is the decision-making hierarchy in the family. The decision about taking the medication or not appears not to rest with the client himself or even his parents, but with an older relative, which again, as Winnie was saying, is quite common in traditional Asian families. So in order to work effectively with this family, we first need to clarify the decision-making hierarchy in the family and then try to engage that decision maker in a dialogue of the basis of its concerns about the medication. Having opened this two-way discussion, we can then provide psychoeducation to communicate factual information regarding risks and benefits of medication, while at the same time addressing his traditionally based fears. We can also look for common ground by discussing appropriate roles for traditional healing methods in conjunction with the Western treatment approaches. And we can also praise the uncle for the concern that he shows for his nephew, thereby pointing out the importance of his role within the family in ensuring that his nephew gets the medical treatment that he needs. In our second case example of a potential cultural conflict in a Tay context, here we see a strained relationship between a 16-year-old male and his mother who complains about his anger, disobedience, and mildly declining school performance. The young man is enrolled in several advanced placement classes, which he greatly dislikes, and he and his mother frequently argue over his future career path. He foresees a future in graphic design, whereas mother insists that he enter medicine or engineering. So, in the interest of full disclosure, I am a physician, so I may be a little bit biased. I don't necessarily see medicine as a bad career choice, but on the other hand, it is a stressful occupation and it's not a good fit for everyone. So while the Tay in our example sees himself in a more artistic or creative career, his mother appears to be more focused on occupations that are traditionally held in high esteem in their culture, and she emphasizes the necessity of academic excellence if one is to get into, quote, a good college. So mother is greatly distressed here by the relatively mild decrease in his grades, worrying about the implications for his future and how that would in turn reflect on the family as a whole. So clearly, a case like this calls out for family therapy, although I will oftentimes refer to these sessions not as family therapy, but as family meetings in order to de-emphasize the stigma of therapy and mental illness. In the process of family therapy, we often start with acknowledging that a stalemate has been reached and that escalating the conflicts further are unlikely to produce the desired outcomes for either side. Next, we try to help each side see the other's actions as a positive in the appropriate cultural context, framing the adolescent's struggle to find balance between the two cultural contexts that he or she is expected to function in equally well in, and helping the adolescent recognize the love implicit in the parent's efforts to ensure his success rather than it just being nagging or arising out of a need to control his life. We can also help impart empathy by trying to elicit some of the parent's own ambivalence towards his or her native country and culture, as this often underlines or underlies their decision, as well as the decision of many immigrants to leave their home country for the U.S. Now, these, of course, are just two examples. Obviously, there are many other potential cultural conflicts that may arise for the Asian American TAE, and we can't possibly address every potential situation in the time limitations here. So instead, I do want to point you to a useful resource that's available in the back of your DSM-5 manual, and that's the cultural formulation and the semi-structured cultural formulation interview. This interview is a semi-structured interview consisting of 16 questions, along with additional supplementary questions that are available on the APA's website, and the URL is listed down at the bottom of the slide. And these questions can help guide you through a thorough cultural assessment, and the process of eliciting these issues that are listed here on this slide will often naturally lead to a clear path for intervention once the relevant cultural issues and factors have been identified. And so with that, I'd like to pass the program over to our next speaker, Angela, who will talk about working with the adult range. Thank you.
Thank you, Dr. Sevilla. I'm just trying to move over the next slide. There we go. Thank you. I will be speaking about culturally competent practices for the API community's adult age population. I wanted to give an introduction to our API Adult Collaborative. We're a collaborative of partner agencies throughout LA County. This also includes our core staff. Due to diverse cultural and linguistic needs throughout LA County, the API Adult Collaborative has county-wide services. We serve individuals aged 26 to 59. We have bilingual and bicultural staff, meaning that the staff have a good working understanding and knowledge of Western and Eastern cultures. Our multidisciplinary team includes clinicians, case managers, nurses, psychiatrists, substance abuse counselors, and outreach workers. Due to our collaboration, our language capacity includes Bangla, Cantonese, Chuchao, Gujarati, Hindi, Hmong, Japanese, Korean, Khmer, Mandarin, Punjabi, Samoan, Tagalog, Thai, Toisanese, Urdu, and Vietnamese. I do want to take a moment to acknowledge our API Collaborative's partners who makes this work possible, and they are Asian Pacific Counseling and Treatment Center, Asian Pacific Family Center, AP Recovery, Coastal Asian Pacific Mental Health, Long Beach Asian Pacific Mental Health, the Office of Samoan Affairs, Samoan National Nurses Association, Pacific Asian Counseling Services, South Asian Helpline and Referral Agency, and the South Asian Network. To effectively work with the API community, it's important to have an understanding of the worldview, values, and behaviors of the individual as well as the family. We'll be taking a look at important areas to consider when working with the API adult. We want to look at their level of cultural identification and acculturation. There exist common themes in the API community. However, there also exists great diversity within a group and between API groups. The experience of a 30-year-old Chinese male born in China who came to the States a year ago is going to be vastly different than that of a 30-year-old male born in China who came 15 years ago versus a 30-year-old male Chinese client born in the States. And Dr. Hsieh did allude to just the great diversity within our community. We need to assess the cultural identification. This is going to assist in guiding treatment. We want to look at acculturation level, and that can depend on age of the immigration for the individual, language identity, exposure to Western culture, cultural and ethnic pride, ethnic makeup of the new neighborhood, socioeconomic status and job, and immigration status. We want to look at the cultural views regarding mental health. We want to identify how mental health issues are seen and regarded by the individual and their cultural lens. In the API communities, mental health can be seen as stigmatizing and a reflection on the entire family. In many API communities, there isn't a word in the language that translates to mental health or therapy. Only crazy. We also want to explore help-seeking views. The API community is not typically taught to seek help or to focus on self. The person may just be encouraged to not think about their problems. We want to look at their cultural customs and traditions. This includes ancestor worship, family celebrations, weddings, funeral rites. All of these serve to reinforce the concept of the individual's defined role in the family. We want to look at communication process. Use of indirect communication is common and accepted as the norm. Due to the traditional hierarchy of API families, verbal expression of emotions is not encouraged. Negative feelings such as sadness may be expressed in an indirect manner, as well as positive feelings such as love. As clinicians, we need to be cautious to not automatically label this type of communication as resistant or passive-aggressive. We want to look at the level and use of the person support system. API culture highlights faith, family, friends, and the cultural community. For support in general and in times of crisis, API families tend to go to extended family members, friends, monks, the clergy, healers, elders, or herbalists, or the community organizations. The mental health professional is not usually the first person thought out, but the last. Partnering with this identified support system can be useful in the treatment process. We want to look at the impact of faith on the belief system. The API community comes from a diversity of religious backgrounds. The treatment providers should encourage individuals to share their faith beliefs in relation to their problem and problem-solving skills if it's been identified as important. A spiritual leader can be an important person to align with in the process of comprehending and working out of individual and family problems. We want to look at issues of interdependence. How much does the individual identify with the group focus? We want to look at how they identify within the family structure. How does the individual see their identity? How does the family view their identity? We want to look at the immigration experience. Each group has a unique immigration history into the U.S. It's important to have an understanding of the immigration experience and how the stress of immigration and adjusting to a new culture can affect one's mental health. We want to review trauma experience. A common theme among many Asian countries is that most have suffered political unrest and war. Many individuals suffered from physical trauma or psychological trauma. Southeast Asian refugees in particular have high rates of PTSD and depression. Depending on one's own experience with trauma and their government in their country of origin, there may be a mistrust of mental health professionals as being a part of the government system. And we've actually seen this in the area of even just finding any formal documentation needed for treatment services. The clinician needs to remain sensitive to any trauma issues within the API community. We want to assess for their views about discrimination. Historically, Asians have been subjected to many forms of discrimination and racism in the United States. Many clients report experiencing discrimination currently, whether related to their physical appearance, their accent, or in other areas. Clinicians should be sensitive to the impact of experienced discrimination for the individual. In our work with the Amerasian community, many report feeling straddled between both cultures, not fully accepted by either. Particularly for those born during the Vietnam War, they report experiencing great stigma because of their appearance. Not fully Asian, not fully American. Clinicians should also be aware of any issues with internalized discrimination. And in our work with some of our Amerasian clients, what we've done is just really help to pull strengths from both of their cultures. We want to look at age span issues. In the API culture, a clear hierarchy of authority exists. Usually the father, as the head of the family, makes decisions. At times, the children or the parent becomes the caretaker or conservator, and this can result in conflict within the relationship. We've had many clients whose children were their conservators or their caretakers, and the adult parent would try to dictate to the oldest son or the oldest daughter regarding their treatment or any care related to them. We want to look at issues of loss with adults in terms of productivity, in terms of work status, economic stress, just in general issues of loss of one's identity, their dreams, or their goals. And we've noticed in our work that family members can have a great sense of loss as well because there can be such a close relationship within the family structure. We want to explore and validate the family sense of loss. In terms of shame, for many APIs, acknowledging the presence of mental health issues can bring very strong feelings of shame. The shame can be so strong that it can prevent APIs from seeking help. It's important for the treatment provider to be aware of the intensity of the shame, to acknowledge it, normalize it, and to just work collaboratively with the individual. Now I want to talk about some strategies that we've utilized. Diversity within API communities can often be overlooked. We want to avoid the notion of sameness. We want to be aware of cultural differences and embrace them. A treatment provider can share one's gained knowledge with their client. We believe that individuals know themselves and that intervention should be matched with the client's perspectives and worldview. Treatment providers can work with the client in incorporating the holistic approach of the Eastern culture with the best Western medical and psychological practices. We have many clients, in addition to their psychotropic medication, who are active with acupuncture or yoga or taking herbal medication. Most Asian Pacific Islander individuals desire practical and immediate solutions for their concerns. We utilize solution-focused, time-specific approaches. There's a lot of concrete goal setting that we do that can be effective. I'm sorry, let me move to that slide. Individuals who seek treatment for more severe psychiatric conditions We also want to educate them that a longer period of time for their treatment may be required. We want to explore the influence of family and community in addition to individual perspectives. You want to use family care and commitment to the individual as a valuable resource. We partner with faith-based spiritual leaders and cultural leaders of the community. We collaborate with community organizations such as medical doctors. These are the strengths and resiliency of the cultural community. Our goal is to educate. Education needs to occur on multiple levels, including the individual, family, and community. In addition to informing about symptoms and treatment, the goal is to educate about wellness and recovery. The individuals with mental health issues can lead productive lives. We want to promote acceptance so that there's a shift in thinking, a change in attitude, and decreased stigma. One strategy that can be effective is to start the engagement with non-stigmatizing and empowering terms. We use terms such as emotional health, spiritual well-being, wellness, and wisdom. These are relatable concepts to the HI community. Now I'm going to talk specifically about mental health services in the South Asian community. And the countries of South Asia include Afghanistan, Pakistan, India, Nepal, Bhutan, Bangladesh, Sri Lanka, and Maldives. Each region has multiple languages, religions, and customs. There are some specific challenges specific to the South Asian community. One is that therapy is not a word in the culture, and it can't be translated. This makes explaining and understanding treatment sometimes challenging. There's a lack of insight into emotions in the community. There's sometimes a difficulty identifying and labeling feelings. The community isn't emotion-based and encouraged to speak about feelings. The focus is on education, family obligation, and responsibility. Punctuality and attendance issues can be the norm. This can be cultural. There can be a lack of consistency, but it doesn't necessarily mean that there is resistance, but it still can have an impact on treatment. Young clinicians may not be regarded, so as a young clinician, one may be asked, how old are you? Due to respect for the elderly in the community and a system of hierarchy, this question may come up. Psychosomatic symptoms can be seen as real medical conditions, and there may be a desire for health medication as a quick fix without an examination of other issues. There are multiple languages spoken and religions in each region. Each region has their own set of cultural beliefs in relation to clothing, food, ceremonies, weddings, and funerals. The lack of acculturation can have an impact on progress, and private space for home visits can be difficult due to extended families living together. Some of the strategies that have been effective in the South Asian community include referring to oneself as educated and experienced in teaching skills to clients. Since education is valued in the South Asian community, one can reference schooling, education, and experience that you've had. The community also values tangibleness. Inform individuals you are open to, you're able to teach and model skills. I'm sorry, can we go back to strategies?
Sure, just a second.
Sorry about that. Thank you. Sorry about that. In the South Asian community, one can be open to accepting food at home visits. This is very much a cultural act. Within clinical judgment, agency guidelines, this can be something that's acceptable. You want to tell clients that they are the experts in their culture and that you want to learn more. have a genuine interest in who they are, where they come from, and what experiences they've lived. Individuals are open to medication and opinions of the medical doctor more so than the clinician. Many South Asians will go to a medical doctor for health issues. There are many medical providers in the South Asian community, and a strategy is to partner and align with medical providers. One needs to show respect to the elderly by calling them Mr. or Mrs. The elderly are seen as very wise, and this is an important gesture. Actually, if the clinician was South Asian, they would be calling the individual uncle or auntie, and that's appropriate in the community. One can assign concrete homework: walking, praying, meditating, listening to music, journaling. And journaling is actually becoming popular in the South Asian community, but the clinician just needs to provide structure to that activity. Progressive muscle relaxation techniques are effective, and yoga is effective as well, particularly due to its cultural roots. You want to involve the family with permission to be a part of the treatment. And termination may take longer once a therapeutic relationship has been built. The clinician may be considered like family, but what the treatment team does is that they utilize strong therapeutic bonds in the treatment as a strength. And strength-based and solution-focused techniques have been effective with the community. Next, I want to talk about Eva. Eva is a 41-year-old South Asian Indian woman who is married for 19 years and has 2 adult daughters. Eva and her husband had a seemingly good married life and were viewed as the perfect couple. Eva found out that her husband was having an extramarital affair and they separated. After the separation, Eva had to find employment, move out of her house, and change her lifestyle. This is an individual that our team was working with, and Eva was urged to seek treatment from a family member. She had actually never been in any kind of treatment before. But with the urging of a family member and due to her crisis, she agreed. Eva did not desire to take any psychotropic medication, and the team assessed that she was actually safe and not a risk to herself. The treatment team worked on issues of grief, anger, loss, and a new identity formation with Eva. Eva had a difficult time fully investing in her treatment. She began to display signs of depression. She became isolated and did not want to see her friends or family. She reported feeling hopeless about her future without her husband. She had difficulty sleeping, lost her appetite, and did not show any interest in activities that she normally enjoyed. Eva spent most of her day in a depressed mood and cried all the time. She worried all the time about her husband and her future. Eva is actually one of our success stories, and the team worked really hard with her and just her support system. And what they did was, with her permission, the therapist encouraged Eva's family to check in on her every day to show her support and love. Her friends and anyone a part of her support system were utilized as part of her treatment. Her support system was fully invested in her recovery. In addition to the emotional support Eva received from her clinician, there were concrete and tangible goals for Eva. Eva's family and friends encouraged her to learn how to drive and to become independent. Eva worked with her case manager to gain employment and to explore housing options. She began working outside the home for the first time, visiting church more often, participating in social activities, and reintegrating into the community. So I just wanted to share with you about the work that was done with Eva in the South Asian community. And so now, thank you for your time, and I'll turn it over to Yvonne's son to talk about the older adult community.
Thank you, Angela. Let me just activate the slide. My name is Yvonne, and I am the Division Director at Special Service for Groups Older Adults Division. I will be presenting today on the Asian and Pacific Islander older adults population.
The SSG Older Adults Division was initially developed in 1999 to meet the needs of Asian and Pacific Islander older adults with limited access to community resources due to barriers associated with cultural and linguistic barriers. The division was developed with limited funding from Los Angeles County Area Agency on Aging to provide case management services to homebound API older adults. To represent the diverse needs of the API community in Los Angeles County, the division was developed as the central coordinating agency of a collaborative partnership with a number of community-based organizations. In 2007, the division expanded our services to include mental health services with the funding through Los Angeles County's Department of Mental Health. The mental health programs now include a range of services from prevention and early intervention to field-capable clinical services and full-service partnerships. As with the adult program previously presented by Angela, the older adult program also consists of a collaboration of a number of community-based organizations that have a long-standing relationship within each of the API communities served. Currently, over 50 staff persons make up this network of service providers, and the program has the capacity to provide services in over 10 API languages. The content of this presentation is derived from the work of these providers since the development of these programs. For the purpose of this presentation, I will first cover some of the issues that impact access to services, service utilization, and outcome of service delivered. Then I will provide some strategies that have proven to be effective in our work. I will end with 2 vignettes. I've broken down the challenges that prevent successful intervention into 2 categories, systemic and individual. On the systemic level, I want to start with the difference in perception of older adults and how it impacts engagement and proper assessment. Ageism, unfortunately, is a very prevalent concept in Western society. Older adults are depicted in the media often as the grumpy old man. There is a general perception that depression, isolation, and dementia is a normal part of aging, and that old age is accompanied by slowing down and reduction in the role in society. We have the term senile that is often used to define older adults who is weakened by disease and old age. These symptoms thought to accompany old age is perceived to be irreversible and not worthy of effort and treatment. This perception makes it difficult for clinicians to validate the loss experienced by older adults and to appreciate the sense of failure to contribute in a meaningful way to society. Conversely, in the API culture, older adults are generally revered and sought after by younger generations as a source of wisdom. Second, as mentioned earlier, there is the general lack of understanding of the diversity of the API community. Many API older adults often incorrectly identified as being part of a different group to which they do not belong. There is also a lack of available bilingual and bicultural workforce within the API community. The stigma attached to mental health limits the number of students pursuing this field. When a staff is available, they are generally young and may themselves lack the understanding of the culture and historical context that greatly impact the client's presenting problem. As mentioned in earlier parts of this presentation, the focus of individualism can also pose a barrier. Finally, the focus on open communication, exploration of feelings, and intrapsychic conflicts can oftentimes be uncomfortable for API older adults, who are more accustomed to discussing their life in a more indirect and abstract manner, especially when speaking to someone younger to them. When they attempt to share the difficulties are mislabeled as resistance to treatment and avoidance, the API older adult may drop out of treatment without disclosing feelings of disrespect and insult. They may also avoid further contact with mental health professionals in fear of being further misunderstood and invalidated. Moving on to the individual challenges, as mentioned earlier in the presentation, immigration status and circumstance of immigration can play a major role in help seeking. For API older adults, leaving their homeland may not have been a choice. Some enter the country as a refugee or has asylum status, and returning to their home is not an option. Others chose to enter the country later on in life to join their adult children, who may have pursued higher education in the United States and decided to stay in the United States. Many that enter the U.S. at later age in his or her life have difficulty with adjustment and still hold on to traditional values about family structure and relationships with adult children and grandchildren that may be a mismatch to the reality once they left their home behind. There is generally a huge sense of loss and disappointment that contributes to late life onset of mental health issues when the older adult is not able to make a smooth transition to their new life in the U.S. It is also important to examine the historical context in which the older adults have had to navigate through in the course of his or her life. For many older API immigrants, they experienced some type of war or political unrest in their homeland prior to coming to the United States. These experiences impact their perception of the cause of their illness, their presentation of their illness, their willingness to accept treatment, and their belief in how treatment is defined. I will briefly cover a few of the major historical events in this presentation that were experienced by many of the seniors we serve. This is in no way an exhaustive list, but will hopefully provide some understanding of the history of the API older adult. First, I will cover China. After Chairman Mao implemented communism in China, the Cultural Revolution was launched in May of 1966. The revolution was to remove class struggles, and many of China's youth formed the Red Guard, and along with the communist leadership, persecuted senior officials and scholars who were accused of taking a capitalist direction. Millions of people were persecuted during this time and suffered a wide range of abuses, including public humiliation, arbitrary imprisonment, torture, sustained harassment, and seizure of property. Some seniors that experienced this persecution reported being hauled by the Red Army and displayed and stoned in public courtyards. Younger individuals recall being placed in exile in rural areas of the country separated from their families. While the revolution officially ended in 1969, the atrocities continued well into the mid-1970s. In 1989, many older adults were re-traumatized as they watched the events of Tiananmen Square unfold. While for many it was a historical event that brought national attention and change, for many others it was a reminder that the invisible hand of the Communist Party and the trauma previously experienced. Many of the U.S. recall the Korean War that took place between 1950 and 1953 due to the involvement of the U.S. military. However, it is rarely mentioned that the Korean War followed 35 years of imperial Japanese rule. For many older adults that lived during this period and recall the rule by the Japanese, working with social workers or professionals of Japanese descent may be unacceptable. Some lost a spouse or a parent due to Japanese imprisonment. However, it is also not uncommon to find Korean older adults who can also speak Japanese fluently due to this period of Japanese rule and are comfortable with working with either a Japanese or a Korean professional. Another historical event that is well documented in the U.S. is the Vietnam War that took place between 1955 and 1975. What is not documented is the impact of the war on neighboring countries such as Indonesia, Laos, and Cambodia. Southeast Asia is a region consisting of a number of small countries closely linked to one another. Many individuals fled the war in Vietnam and went to neighboring countries for survival. This also meant that the impact of the war also negatively impacted these neighboring countries. Many of the citizens of Indonesia, Laos, Cambodia were also casualties of the Vietnam War. In Cambodia, the ethnic cleansing or genocide of individuals with partial Chinese or Vietnamese ancestry took place between 1975 and 1979, led by Pol Pot, the leader of the Khmer Rouge or the Red Khmer. To reinforce communist ideology, people were driven from their homes and placed in farmlands to work the land. Many who were perceived as intellectuals or appeared to have stereotypes of a learned person was killed. To date, approximately 20,000 mass graves have been located in the Khmer Rouge era across Cambodia, and it is estimated that approximately 2 million people died, half due to executions and the other half due to starvation or lack of medical treatment. Some older adults that were served by a program reported witnessing their entire family being slaughtered in front of their eyes. One client reported watching her husband and 11 out of 12 children getting murdered, as she herself was raped and beaten half to death. The images of the execution sites, later named the killing fields, are too graphic to include here. The South Asian community was covered in depth in the adult section, thus I will not go into detail here, but to mention the recent events of 9/11 and the negative impact it has made on an already challenging community to engage. Many of the South Asian, Asian Indian, or Pakistani descent were subject to racial profiling and victims of hate crimes following the events of 9/11, increasing the fear of this community to seek out for assistance. Lastly, not to be overlooked is the events of World War II and the impact it had on Japanese American older adults. Some recall being at Hiroshima and Nagasaki when the nuclear bombs were dropped. Others were residents of the internment camps that were set up here in the U.S. Through our experience working with Japanese older adults who may have been youth during these events, we have found emotional detachment and dissociation to be common characteristics when coping with emotional stressors. Other individual characteristics worthy of some mention here are the traditional Asian notions and beliefs, relationships with nuclear family, and the older adult experience with formal education and systems from which many of the therapeutic concepts and modalities are formulated. It is important to note though that this is a generalized illustration and individual differences within and between the various API groups exist. For many API older adults, traditional values are a very big part of how they perceive and resolve personal challenges. Many follow Eastern religion and Confucius thinking that values the concept of karma, personal suffering, as a way to reach deeper personal growth and enlightenment. This may be viewed by some professionals as a lack of sense of personal control over one's life challenges or an external locus of control, and can then be perceived as a resistance to make personal effort to change while in a challenging situation. For many others, mostly of Southeast Asian descent, indigenous beliefs and practices are common. It is not unusual for a Cambodian older adult to report that the source of his or her problem is a hex or curse that has been placed on their home, and that a shaman is needed to be rid of the possession. Some API older adults will avoid entering into treatment to prevent shame that will be brought upon the entire family unit, unless the emotional distress has caused considerable distress to the larger unit of the family system. This is also true even if the emotional distress is primarily rooted in difficulties that they may be experiencing with their adult children. The relationship with the adult children has proven to be one of the major sources of late life onset mental health issues due to the strong identification of personal success and the success and relationship with adult children and grandchildren in late life. Some challenges faced by older adults is lack of understanding of traditional cultural beliefs and practices by their adult children. They may also experience communication challenges, as many of the adult children who were raised here in the U.S. may not be fluent in their native API language. Finally, as noted earlier, many of the historical events that took place during the life of the older adult may have prevented the older adult from receiving any type of formal education. Some are illiterate in their native language. Further, the lack of experience with formal educational system and work environments may make it challenging for older adults to follow through on some recommendations made by clinicians. Some of the strategies that we have used that are effective in working with API older adults include integrating cultural beliefs and values into our intervention, making sure to address the cultural specific beliefs around the origin and treatment of illness, being open to non-traditional approaches that may challenge our comfort level as a clinician, working with family spokesperson, community leaders, gatekeepers, and other cultural brokers may be essential. Consider intergenerational issues within the nuclear family, and allowing room for abstract and circular discussion rather than an open and direct verbal communication of their feelings. Now I will illustrate those interventions in 2 case vignettes. The first case is a 64-year-old Vietnamese man that we had worked with in our program. The client was referred to us for services by an outpatient mental health agency after the client's symptoms worsened and become less stable and willing to come to the clinic for treatment. According to the referral source, the client had been exhibiting symptoms of depression, including insomnia, depression, loss of energy and interest, feelings of hopelessness and helplessness, and isolation for an extended period of time. The referral source was particularly concerned of the client due to increase in late-night screaming due to night terrors and bizarre behavior during the day, including refusal to leave the house and hiding behind living room couch to avoid windows, insisting that the dead are looking for him. The client has had a long history of depressive symptoms since his youth due to living in poverty in Vietnam. The client reported that he joined the Army against his will, and post-combat in 1975, he experienced some symptoms of PTSD and depression, but he did not seek treatment at that time. The client worked as a rice farmer in Vietnam for most of his life and immigrated to the U.S. in 1988, at which point he was able to work as a restaurant worker for 6 years. The client began experiencing symptoms again following the 9/11 after watching repeated images of combat on television. In 2004, the client's symptoms reached a point where he will no longer be able to focus and he lost his employment. The client was prescribed psychotropic medication but was only moderately compliant with the medication. Upon the initial meeting with the client reported that he was being punished because he had committed a sin. The client reported that he allowed the bodies of his comrades to be left unburied without proper Buddhist ceremony to help the souls pass on, and they are now seeking him out for retribution. The client reports seeing the dead soldiers outside of his home waiting to take him with them. The client did not feel that there was any remedy for his problem and felt that he should take his punishment. The client lived with his wife and adult son, and he had a strained relationship with his son, which contributed to his depression. The client believes that his son does not respect him because he is not able to work, and that his wife is now the sole income of the family. The client felt useless and ashamed of his inability to return to work and feels that this contributed to his son's inability to maintain stable employment. To address the client's mental health needs, psychoeducation was provided to the client and his family about his illness. Clinicians incorporated client's cultural beliefs in the intervention to assist the client in developing a sense of control over his situation. The clinician worked with the client's wife to bring the client to a local Buddhist temple to receive consultation. An altar was set up in the client's home where the client can repent and pray for the souls of his fallen comrades. A A chanting machine was also obtained to help the client with his night terrors. A few family sessions were conducted to help the client improve communication with his son. The client's son has spent most of his teens in the U.S. did not understand his father's communication style and expectations. However, was able to express his sincere concern for the client's well-being and reduce client's concern of being rejected by his son due to being useless. The son agreed to participate in client's treatment by participating in weekly temple visits with the client and a blessing ceremony that was completed for the fallen soldiers. To the Asian culture, incorporating your family and children is a sign of sincerity and brought the client comfort. The client became much more compliant with his medication therapy as a result of these interventions and was able to improve his functioning. The second case I want to discuss today is a Japanese woman with bipolar disorder. This client is a 69-year-old first-generation Japanese-American woman who is monolingual Japanese. She was referred to SSG following 3 suicide attempts while she was admitted in an inpatient psychiatric unit. The hospital was unable to communicate with the client due to her language barriers, but attempted to utilize the client's adult children to provide interpretation and assist in treatment. The hospital was unaware that the client's adult children were not fluent in Japanese and was not able to fully communicate with the client. The client has 4 adult children, 3 sons, and 1 daughter. The client's husband was deceased, and the client resided with her adult sons, and she had an estranged relationship with her daughter. After the initial meeting with the client, it became clear that the client was extremely isolated. The client became tearful immediately after meeting the Japanese-speaking clinician, indicating that she had not been able to communicate with anyone, including her children, for almost 10 years. When the client's daughter was finally contacted, the client's daughter disclosed that she had been trying to get her mom into treatment for some time now. However, her siblings and mother denies that the client has any type of mental illness and indicated that her wrong thinking was due to her chosen lifestyle. The client's daughter has a son born through wedlock with her Hispanic boyfriend and works as a hairstylist and a tattoo designer. This was a source of shame for the client. Upon discharge from the hospital, the clinician found that while the client lived with her sons, she was mostly left alone in the home. While the client reported being satisfied with her relationship with her son, she did not feel comfortable talking to her son due to cultural factors and language barriers. The client began to report that the tree in front of her house sounded like the sirens during the war in Japan, caused her sleeplessness. The son proceeded to chop the tree down. However, they did not refill the client's medications or pursue any additional treatment for her, even though she was gardening in the backyard in the middle of the night and continuing to have sleepless nights. Following some months of treatment, it became clear that the client was reluctant to discuss her illness, but was much more focused on her isolation and relationship with her children. The client shared her disappointments, but discussed very little about her feelings or mood and continued to refuse to take medication. When connected with the local Japanese community center, the client was reluctant to attend, indicating that it would be shameful to go seek social relationships outside of her nuclear family. The clinician and caseworker conducted a few family sessions to discuss the client's feelings with the client's children and further educate the children on the client's illness. During these sessions, the daughter disclosed that she had suffered from bipolar disorder for many years and had been in treatment. The daughter's disclosure of her illness and the isolation and rejection she felt by her family brought more acceptance from the son, and all agreed to plan to work together to improve the client's overall mental health. The sons took turns throughout the week to manage client's medications, and all of the children arranged to have one family meal with the client weekly. To help them better understand the Japanese culture and improve communication with the mother, the daughter began taking the client to the Japanese community center. Although the client was never able to participate in traditional psychotherapy, and frequently used the time in therapy to share stories of her childhood and of raising her children, the client was better able to manage her illness with the assistance of her children. That concludes my part of the presentation.
Okay, thank you. Thanks to each of you for your wonderful presentation and all the information that you've provided this morning. This is Christy Higgins again from CIMH, and we are ready at this point to entertain questions from the audience that you may have, or comments that you have for our panelists, our presenters. We have had a couple of questions come in already, and I will go ahead and read the first one, and we'll let each of the presenters know that we are unmuting you so that you can kind of respond open-ended to the questions as they're asked. And to those of you who are listening in, please do take a minute if you have any questions that you have, again, to use your question box feature and submit those to us now. But the first question, question number 1, is, can you elaborate more on gift giving? Is it appropriate to accept, or the standard is to reject? Where do you draw the line?
This is a great question. Generally, I want you to refer back to your agency's policy. But when working with API communities, what we've found within the collaborative with multiple agencies is that, generally speaking, we accept food items. So we will let the family know that we thank them very much for their thoughts, and that we will share them with our colleagues. And we let them know that, please don't burden themselves with giving us any gifts or food in the future, because, the populations that we serve, a lot of times they are from lower socioeconomic status. So to give you food, I just wanted to let the family know that we don't want to give them undue burden, that they have to go out and purchase and so on and forth. But that doesn't stop the families from giving us food that they made for holidays and so on. And generally we do take them, and we just let the family know that we appreciate their thoughts and we'll be sharing them. Now, as far as monetary or like gift items, within the collaborative, we've been presented with gold rings, necklace, clothing, and anything you could think of. And we don't accept them, and we just let the family know that we appreciate that they have us on their thoughts, and the best gift that they can give us is that the family is doing well, the client's doing well, and we're working with younger kids especially. We just tell the family that we would take a homemade card, letting us know that they're doing well instead of any gift items. So we reject most of the gift items except when there's food. But then again, you wanted to go back to your agency policy and see what is acceptable for your agency. And we do use that also in our conversation with our families, that is the agency policy that we cannot accept X, Y, Z. And a lot of times when family offer you food or tea when you go out on the field visit, we wanted to keep in mind that because of their financial status or their living environment or their situation, that might be the most that they can offer you, and they really want you to have that cup of green tea. And to turn it down could actually mean something significant to them. So generally speaking, we don't turn down tea that's offered or water that's offered, because to offer that, they also wanted to let you know that they're welcoming you into their family, into their home. So generally speaking, our staff don't want tea or water. So again, go back to your agency and talk to your supervisors and management and decide what would be the appropriate thing to do for your agency.
Okay, great. Thank you for that comprehensive answer to question number 1. We have a second question, and that is, How do you deal with HIPAA considerations when involving extended family of an adult?
Hi, this is Angela Kang, and thank you for the question. What we do when we begin treatment with any individual is that we find out who they want involved in their treatment, and what we would do is we would have them sign a release for each person. From there, it's an ongoing discussion as to how much does the individual want the family involved, what does the individual want the family to know. Even though involving the family is really important in our work, since the client is our primary client, it's an ongoing discussion from there. So we wouldn't be telling details of a one-on-one session that the client wouldn't want to share or that's not relevant. With family meetings that we may have with the client and the family, there's an understanding with the individual as to how that's going to be set up.
Okay, great. Thank you for that.
Mm-hmm.
We have a third question, and question number 3 is, how appropriate is the use of interpreters for therapy when the therapist is serving API older adults? Is there one of you that would like to respond to that first?
Oh, sorry, I had myself on mute.
Okay.
But this is Yvonne from SSD's Older Adults Division. And since this pertains to older adults, I think I'll take a stab at it. I would say that generally it's not the ideal situation to use an interpreter in working with an older adult. However, we do understand that sometimes those situations do happen. It is important that when working with an interpreter, or what we may sometimes call a cultural broker, that the individual is not only bilingual but also bicultural, and will be able to work with the clinician in translating some of the cultural nuances that may be unspoken or spoken during the dialogue with the older adult. And I think always refer to the older adult as the expert, and allows them additional opportunities to share with us their culture so that we can be more successful when utilizing the interpreter.
Okay, great. I'd like to give, I'm not sure if it's a bit of a question and a comment combined, so I'll read it aloud, and then if there's more you'd like to anyone expand on related to this, please feel free. So it's question number 4, comment number 4. It speaks to the trauma history of Filipinos, Pacific Islanders, especially the long drawn-out Western colonization, forced assimilation. And then there's another comment related to, from the same person, LGBTQ API mental health challenges, and unique experiences of young adults from 18 to 29-year-olds, which are in distinct contrast to 30-plus in senior adults. So I think it's a bit of a question, comment combined.
Yeah, that probably falls most closest to my age range. This is Brent Smith.
Okay.
I'm not sure I entirely understand the question, but I'll try to address what I can think about and make sense of.
Okay.
Maybe with regard to the LGBTQ Asian population, I think there's some unique aspects that come up for that may be somewhat distinct from working with other subpopulations within the Asian American communities. Many of the people that I've worked with have expressed a sense of alienation and rejection from their community of culture because of their sexual orientation. Many traditional Asian cultures have very negative views towards sexual orientations other than heterosexuality, and for the Asian cultures that have a strong Christian or Catholic tradition, like say in South Korea, the attitudes towards LGBTQ individuals may be very much colored by conservative religious beliefs as well. And so oftentimes we find that Asian and Pacific Islander American LGBTQs are more comfortable in working with mainstream cultural organizations that focus on LGBTQ populations than Asian organizations such as ours. This was especially true for one 40-year-old Korean immigrant who is HIV positive, who was experiencing a lot of struggles, a lot of stereotyping and rejection from the community, from the Korean community here in Los Angeles, and tended to feel much more comfortable in Westwood or other gay-friendly environments. So to address that from the bicultural standpoint winds up being a bit more challenging. We may, in fact, be less traditional than, say, if we were working with some of the older adults that Yvonne was describing.
Okay. I have a comment and then a couple more questions. So the comment from one participant says, thank you for holding this seminar. I can completely relate with this webinar, having grown up as a second-generation Taiwanese American. I'm a mental consumer and have been sharing my personal story since July of 2013. So thank you for those comments. Another question, someone was asking about page 10. What is the dyad in page 10?
Was that one of my slides, I'm guessing?
I was trying to look through the slides to see specifically what dyad, what question that was.
But if you send I think mine would fall under page 10, but it's not in the children's presentation.
I mean, in general, a dyad refers to a relationship or interaction between two people. And I think I had brought it up talking about, you know, development in late adolescence and early adults, with the difference between Western developmental models focusing on dyadic relationships. In other words, relationships between two people, typically romantic relationship partners or parent-child relationships, as contrasted by Eastern emphasis on relationships within a family network, in other words, involving multiple parties. Hope that answers it.
Okay. All right, great. I think that probably answered the question, I hope. I have another question, and it is there a good web resource or handout that could be used to educate clients and or families on the interactions of psych meds with the use of herbs?
I guess that's probably my area, since I'm the psychiatrist on the panel. You know, one limitation about the issue, which is very important, you know, most of the studies that have been done looking at how common the use of complementary alternative medications is in Asian populations is that it's extraordinarily prevalent. And a lot of times the families won't tell you about it, or if they do tell you about it, they don't really know exactly what it is that they're taking. It may be described as a vitamin, or if they're going to say a traditional Chinese herbalist, they'd be presented with a packet of numerous ingredients which, well, are likely to have dozens of active ingredients within those that are then boiled into a soup or a broth to be consumed. And so it makes it tremendously difficult to actually do good scientific studies on what are the risks of interactions between traditional herbal medications and Western prescription medicine. So the lack of data makes it hard to point to good, reliable information to say this is safe, this is not. The NIMH website, if I recall right, does have some resources as far as some of the general considerations with complementary and alternative medications in mental health services. Whether those are available in different languages, I'm not sure off the top of my head. So I would suggest going to the NIMH website, starting there. Failing that, Google's always a good option. Just consider the reliability of the source that the information is coming from.
Okay, perfect. I think we have time for at least one more question, and then if there's any additional ones that you want to send right at this minute, now would be a great time, because we're slowly beginning to lose our time together with our presenters. So the next question is kind of for CIMH, but also for our presenters, and it's asking what efforts are you and other providers making to actively engage the API community to discuss community mental health issues? Because I'm so outspoken about my story, I have personally faced stigma even at my own alma mater high school. I understand that stigma exists. Fortunately, I will become a NAMI Ending the Silence presenter for high school presentations. So what are ways to actively engage the API community to discuss community mental health issues?
I'll take part of the question. As far as engaging the community, I believe several of the API agencies, including APCTC and KYCC and APFC, we are actually doing multiple workshops throughout the years to communities, to parents, to communities in general, discussing about different topics as it related to mental health. So we're hoping through our education to the community at large that we can help the API community gain a better understanding of mental illness and to destigmatize for some of the parents who have kids affected by mental health issues. So those are some of the things that individually at agencies level that we are doing that I know of.
This is Yvonne from the Older Adult Division, and due to the high level of stigma of mental illness in the older adult age group, we do spend a lot of time reaching out to family caregivers, extended family, and other arenas where older adults tend to congregate to reach out to individuals that may be in contact with older adults that are suffering from mental health issues. And by educating these caregivers, we hope to reach out to the older adults.
Okay, great, thank you.
Angela? Oh.
No, go ahead, Angela.
Oh, okay. I just wanted to add on to that question. For us, what we do is a lot of outreach into the community that involves the churches. We all talked a lot about how faith and that community can be really important for the individual. In addition to church outreaches, we do a lot of education and outreach to medical doctors. I think we all spoke in our presentations about just how the cultural community, they may tend to go to a medical doctor first, and that there's trust in that community. So those are different areas in the community, different people in the community that we've partnered with and that we continue to do the outreach. And thank you for this great question and comment. And I think for all of us, just the experience that we have is that stigma in the API community is so deep and it's so ingrained. So it's really about slowly chipping away layers so that we can provide education and acceptance and a shifting of one's attitudes and thoughts towards mental health.
Great, thank you all for your responses. I wanted to just respond in terms of CIMH. I mean, this is part of our effort to help with the dialogue and continue the conversation, to be able to host webinars like this, to also have a Building the Evidence Summit that we are offering at the end of May, where it's an opportunity for various ethnic and cultural and racial populations to come together and to have these conversations about our healing and our health, our mental health, and traditional as well as contemporary ways that we know how to take care of ourselves and to move towards our own healing. So anyway, so we really appreciate everyone's contributions in terms of questions and comments, and our kind of gracious presenters as well. but at this point we are needing to wrap up our webinar, and I want to just make a few comments before we officially close out. I wanted to thank again our presenters, Dr. Winnie Hsieh, Dr. Brett Sevilla, Ms. Angela Kang, and Ms. Yvonne Sun for their incredibly informative presentations and responses to questions. But we are at the end of our time. Before we do sign off, one of the last comments was that they appreciated the webinar and hope that we would be doing more, and so I'm pleased to let you know that we have one more in this series, and it is scheduled in a couple weeks. It will be on Wednesday, April 30th at the same time from 10 a.m. to noon, and the focus is on community-defined practice, lessons learned from caring for our families in the Asian Pacific Islander population. So we invite you to please tune back in and participate in that as well. I wanted to remind you that you can look at the CIMH website and the CIMH YouTube channel within probably a couple of weeks to review the PowerPoints as well as the recordings for today's session and webinar, but also previous webinars in this series, so for the Latino, African American, and Native American communities as well. So we hope, I mentioned just a moment ago, that you will join us on the summit that we're having for building the evidence for cultural and ethnic community-defined practices. It'll be held on Friday, May 30th, 2014 at the Anaheim Crown Plaza. So please take a moment to register for that or contact us if you want additional information. But finally, as we close, we encourage you to take just a few moments to share your feedback as you exit the session. And with that, we will close our broadcast. So thank you again for joining us.